Hello everyone, welcome back. In the series of top 5 diagnoses in emergency neuroradiology, now I'm going to talk about a stroke. So whenever you're going to work, you're going to see stroke cases that they have different naming. They have a stroke code, a stroke alert, whatever it is. So you're going to be down the ER throughout the night and you're going to see these cases coming your way. So before you freaking out, you just need to know what is the steps that you have to take in order to make a good diagnosis for stroke patients. And you know that time is brain, so it's very important to make these diagnoses very quick. Okay, what we need to know, if you are a junior resident, like first or second year, the first thing I would like you to pay attention is perfusion mapping. So when I have these stroke cases, immediately I open up my perfusion mapping. This is a CT perfusion, and this is the standard of care in the United States and in other countries that they have this equipment to perform CT perfusion. So we have some indices. This is the cerebral blood volume. This is the cerebral blood flow, and MTT and Tmax. I immediately look at my Tmax because it's the most important map that we need to look. So, but in other maps, also you see that in this patient in the right cerebral hemisphere, we have the blood volume and blood flow, which is low. And then on Tmax, we see that the time that it takes that its blood goes into the brain parenchyma is going to be increased or delayed. So this is a critical delayed in right cerebral perfusion that shows with red. So that's the scale that shows a normal perfusion, and it goes higher, you're going to have decreased perfusion. So the more red we have is more critical, and yellow is still low perfused, but the red basically shows that this is a critical low perfusion. So now we know that the right side of the brain is just not perfused very well. So now we know there's something going on. So let's go and see what is the calculation for MAPS. So you have different softwares, so we can use Rapid software. Different institutions might have different. The most common one is Rapid, but this one that I'm currently showing is the Waze software. So let's go see what else it shows. So there is a quality control maps that it shows that how much reliability you can put on these data, because this patient might get a lot of motion, and then you see there's some motion degradation on this, and then also on these scales you see that there are some truncation of the arterial input and venous input. But still, I'm going to look into the data to see what it shows me. Okay, we go to the end of it. So this top line and then this bottom one, they are showing different indices. So the top one shows the cerebral blood flow less than 30%. So these numbers are based on clinical trials. So basically there are so many research done, and they decided to just get this cutoff in order to be clinically relevant. So when we have cerebral blood flow less than 30%, that basically it means core infarct. So this is estimation of the core infarct, and we know that this is just not gold standard by CT. The gold standard for infarct volume is going to be MRI. I'm going to show you later on this video. So first of all, we see that the whole cerebral hemisphere on the right side, not the whole of it, but the grid volume, which is basically calculated as 146 cc, is going to be low perfused, has a cerebral blood flow of less than 30%. So this is defined core infarct, and then this area that is shows with the green, it means that there is some areas that are at risk of getting dead or getting infarcted. So this is a delayed Tmax, or means the area that is less perfused, and the volume is 242 cc. So the Tmax more than 6 is the area that is called penumbra, or the area that in the brain is not infarcted yet, but is going to be the risk of infarction pretty soon. And the way that they decide if this patient needs to go to the intervention or not is based on this calculation. So basically we are looking for mismatch between the amount of the brain parenchyma that is already dead and the amount that is salvageable. So basically we are just going to minus this number from this. So basically this is the tissue at risk. Tmax more than 6 is tissue at risk, or penumbra, which is 242 cc, and this is the estimation of the core infarct that the tissue is already dead. So when we just based on these two numbers, we're going to find out the mismatch volume, which is going to be 96 cc. So still a lot of volume, 100 cc of the brain parenchyma can be salvageable. So that's the decision comes by neurosurgery or interventional neuroradiology, that they decide to take this patient to the OR and do thrombectomy or not. But for us as radiologists, so now I know there is some like actionable thing going on here. This patient can enjoy or can benefit from thrombectomy. So now I need to know after perfusion what is going on in my vessels. So after you look at your perfusion mapping, I would like you to just jump into your CTA and look for the responsible vessels. So we know the right side is down, so we have the right ICA, right MCA probably, because based on this perfusion mapping, we know that this is the MCA territory or middle cerebral artery territory. Okay, so now I know I have to find my MCA. So this is the ICA, you know, this is the petrous segment, this is the cavernous segment going all the way up. This is supraclinoid ICA, and this is carotid terminus. And I see an abrupt occlusion or cut over here. You see that? This is just like cut. So the MCA from the proximal, very proximal, is gone. And then you don't see anything like coming down as M2 superior division or inferior division. And if you look at these maps, like you see that the whole left-sided has like some vessels, but we see the paucity of the vessels on the right side. So there is acute large vessel occlusion by definition based on clinical criteria. Large vessel means basically ICA and MCA. There are new data that they're showing that basilar artery also just get benefit from thrombectomy, but for now, remember, when we are talking about LVO or large vessel occlusion in literature, it means ICA and MCA. So now you have to put this in your impression that there is a large vessel occlusion involving the MCA from the proximal. Okay. So next thing, the important thing in a stroke is also talk about the mass effect and talk about the hemorrhagic conversion. So in these patients that they have large area of infarct or large area of at risk of infarct, they are going to be a great risk for hemorrhage afterwards if they do any intervention or if they don't. Like both situation, if you sit on these patients or if you do some intervention, they're going to be risk of hemorrhagic conversion. So when you're reading these CTs, so first of all, you need to say, okay, there is a CT perfusion which is positive, there is a vessel involvement which is basically right MCA complete occlusion, and then if you look at this CT, if like the CTA part with contrast or even without contrast, you're going to see some loss of gray white matter differentiation, as you see. A little bit difficult to see on maybe on this one, but if you look closely, you see that the gray white matter junction in the right cerebral hemisphere is just going to be a little bit like disturbed compared to the left side. You see more area of gray white matter differentiation, but on the right side you just don't see it that well. So that's the early signs of a stroke on CT, that you lose your gray white matter differentiation. Sometimes you see the hyperdense vessel sign is not very well seen here. It means that when you have a clot in your one of your big vessels, you're going to see hyperdensity on that, and that's one of the clues that people used to use when like they didn't have this amount of like luxury or fancy equipment that we have nowadays. So that was used to just find a clot in non-contrast head CT previously, like with hyperdense vessel sign. And then another sign is insular ribbon sign, that basically when you have MCA stroke, you see, as I said, you lose gray white matter junction in the basal ganglia. You see that. So for instance, this is the coated. You see, though you don't see the coated very well. This is the putamen. You don't see the putamen very well on the right side. And then you lose your differentiation of the insular cortex, as you see, and this is called the insular ribbon sign. So these like some fancy terms that you need to know for your exams, or I mean, they used to use these kind of signs when they didn't have CTA or didn't have CT perfusion. But nowadays we just jump into the CT perfusion and we can estimate which areas are getting infarcted, and obviously we have MRI as well. Okay, so when I'm reading this, first of all, I say there is a CT perfusion deficit. There is a large area of penumbra that potentially can just get benefit from thrombectomy. Then I talk about mass effect, and I don't see any hemorrhagic conversion at the moment on this CT, and I don't have a large mass effect or midline shift. So basically, that's what I need to tell my clinicians what's happening in this CTA. Okay. So based on this scenario, patient had left-sided weakness, and they went and they decided to do thrombectomy for this large vessel occlusion, and looks like they were able to reperfuse that vessel. But now you're getting this subsequent MRI to see what happened. So this is a subsequent MRI. You see that the whole right cerebral hemisphere is very edematous, which is basically expected because the areas of core infarct and the CTA was very large to begin with. So you see that all this right cerebral hemisphere, you see that basal ganglia is all very swollen, and it's just like so many edema happening here. And then you see the midline shift, as you see here. So we have subfascial herniation already. And then let's look at the DWI. So this is a hallmark for stroke diagnosis. So the DWI sequence, you see that the whole right cerebral hemisphere is just down. So it's a lot of like a restricted diffusion on the right side involving the basal ganglia. And if you want to be accurate, we have to look at this ADC map. So you see that the right side it is just down. So despite we did intervention, because the area of at risk was very large volume, so we still have a big infarct in the right cerebral hemisphere. And unfortunately, this patient had a huge hemorrhagic conversion. You see that all these areas that is showing on this susceptibility artifact is showing hemorrhagic conversion, and that's why they have a huge mass effect. And this patient subsequently underwent craniectomy to release this mass effect. So the point of all this is in the stroke cases, so it's important for us, we know that these patients clinically have some signs of a stroke. So our job is just to say, is there any tissue that we can salvage? Is there any large vessel occlusion that is actionable by doing thrombectomy? And then in subsequent MRIs, our role is just not saying there's a stroke. So basically, people know patient has clinical symptoms. We have to say how much infarcted tissue we have, do we have any mass effect, and do we have any hemorrhagic conversion. So make sure you just put your relevant and important information for clinicians in your report, and basically it's going to be very easy and straightforward. So just remember to go step by step, CT perfusion, CTA, look for your vessels, and talk about complication. Thank you.